this week's episode. If you're just joining me, I'm Dr. Susan. I'm a board-certified gynecologist and certified menopause practitioner dedicated to helping women in midlife. That includes women just like me who want to feel great now and also set up the best healthy older version of ourselves. So I get a lot of questions about what happens to these individual hormones during the process of perimenopause and menopause. I think most of us now have a baseline education, thank goodness, about the whole topic of menopause, and that's wonderful. But still, I hear a lot of questions that suggest that in some way we've been taught that, yes, now most of us understand from puberty until around age 50 on average, we're producing lots of these three sex hormones, estradiol, progesterone, testosterone, and then they disappear. Well, that's better than what we used to know, which was absolutely nothing, but that's not quite accurate. So now we've got the basic information. Yes, we make lots of those hormones. We're having periods. Our estradiol goes up and down during our cycle. Our progesterone goes up and down as well, but in a different pattern. Testosterone is kind of just generally declining throughout our lives without much change throughout the cycle. That's great to know. And then our ovarian function stops. That's called menopause. And all of those basically go away. Well, wonderful. We've got that basic information. Now I want to delve into it a little bit more because it's not quite that simple. They don't all go away together. In fact, most doctors, if they were taught anything, they were taught something like they just all disappear together. That's what I thought. I was not taught anything about this. Remember, we've talked so much about the lack of education that physicians get. Frankly, it never crossed my mind. There was no teaching about it, but general understanding was you have a bunch of hormones and then they're all gone. Well, let's dig into actually what happens in that middle part that we now call perimenopause, the part between when our hormones are functioning in a healthy way that continues to cause us to be fertile, let's say between 12 and 35-ish, with lots of variation, because perimenopause is defined by variation. We don't know what's going to happen. It's all over the place. But typically around mid-30s or 40, our hormones start changing in a way that's slowly leading towards menopause. So could be 10 years or more where our hormones are doing this funky stuff, right? Well, let's talk about the order in which they go away, because in fact, they don't all go away altogether. It's not like one day they just disappear. No, I wish it was that simple. That would make life a lot easier for all of us, including those of us who are trying to treat it. But actually, in the interim, here's what happens for most patients. And I'll just emphasize most patients, going back to the nothing's predictable idea. You may not fall into this most patients group, but I will tell you most patients do. So let's talk about one of those hormones at a time. Remember, we've got three primary sex hormones that are produced by our ovaries that eventually go away, and that's what we're talking about when we're talking about menopause, perimenopause, or anything to do with that. Number one, estradiol. That is the primary estrogen that we make all our lives, starting at puberty. Most of you know this by now because we've talked about it a lot, but just as a review, estradiol is lowest during our menstrual cycle. Now, this is when we're having periods. Go back to remembering when you were younger. Lowest during a menstrual cycle. It goes up as we produce the follicles, usually just one main one, that's eventually going to release an egg. So our estradiol rises as that follicle, or sometimes two, grows. And then about 2 weeks after our period started, we count day one being the first day of your period, so that's around day 14, obviously. Around 2 weeks after your period started, our estradiol is the very highest. That's when that follicle is really developed, and then it busts open, releases the egg, sometimes two, usually one. And if you don't get pregnant, it drops down again. So estradiol is going up and down in approximately 28-day cycle. Not always. I know if you're thinking, I didn't have 28-day cycles. Yeah, not everybody does this exactly by the book, which is why we say there's a lot of variation. But around 28-day cycles is common, typical, maybe 25, maybe 30. Up and down, and you have another period. So, there it's going, but it's never zero. So when we're younger, a very low day for estradiol around our period might be something like 50, let's just say. 100, something like that. Now, if you're looking at the numbers on a piece of paper drawn by your lab, there are different units of measurement. And I'm not going to confuse you today with those because you really don't care. You just want to look at the number. However, be aware there are different units of measurement for the different hormones, which makes it even more confusing. But let's say on a low day, your estradiol is around 50 to 100. On the highest day around ovulation, it can get really high. Typical might be around 300. Now, if you release 2 eggs, of course, it would be more than that. And a curious thing that happens in perimenopause is it can get really high, 800. I've seen even higher than that. I'll tell you the reason for that in a moment. But suffice to say, it's going up and down. And as we get into perimenopause, the ups are higher and the lows are lower. So estradiol does not go away until way, way late in the picture. In fact, at the time of menopause, estradiol goes away. But prior to that, we're producing lots of it. Yes, in a very up and down manner, but if you added it up throughout the month, we're making lots of estradiol. It's going up and down in a generally downward direction. So yes, we're making less as we progress through perimenopause. But that being said, there are some days where it's extremely high. So it sounds a bit confusing, doesn't it? Perimenopause is confusing. We're telling you your estradiol is dropping. Well, how come it's 800 on the day you measured it? Yeah, that happens. So very, very up and down. We talk about a hormonal roller coaster, hormonal chaos, lots of these type of terms to describe exactly that. But point being, estradiol does not go away until very late in the picture. Now, let's put that one on hold for a moment and talk about progesterone. Well, you might remember this imaginary cycle that we used to have, or maybe you're still having it. We do not produce any progesterone at all during our period or until after that egg is released. After that egg is released on about day 14, if our ovaries are healthy, we make lots of progesterone because progesterone is progestational. That means it keeps the little baby alive. If we get pregnant, that is the hormone that keeps that embryo alive. So if we get pregnant, we continue making lots of progesterone. If we don't get pregnant, well, that drops as well, and we have another period. So we only see progesterone being elevated about a week before our next period. So progesterone's not high every day. It's actually 0 most of the month, and then it goes up in the second half of the cycle, and that is normal, and that's what's been happening all of your life. Little caveat to that is if you get your blood drawn at some random day of the month, you may see that your progesterone's 0, and that may be perfectly normal if it's in the first half of the cycle. So later in this video, I'm going to tell you about when to draw your blood if you do choose to do that, because if it's going up and down, clearly measuring it on one day versus another, you're going to get very different results. So we want to make sure that we are all clear on the correct day to measure labs so that we can all be comparing apples to apples. Well, what happens to progesterone during perimenopause, say from 35 on, is we make less of it. The ovaries are not as healthy, so yes, we may still be releasing an egg. Granted, we're still having a period, yes, but we're not producing as much progesterone because the egg's just getting a little bit older. It's not pumping out as much as it used to. It's a little bit more frail. So we do make some progesterone often, but if we were to measure that level, it's much lower than it used to be. So even when we're still having periods, maybe they're still every 28 days, we're seeing a decline in progesterone, and that is the first hormone that drops. So remember I told you they don't all disappear together? Progesterone starts going down first. Very early on, we can see reduction in progesterone. It's one of the reasons why patients have miscarriages when they're over 35 more often, for example, or why our periods start getting closer together or heavier, or all these type of things start happening that seem kind of normal-ish, but not quite right. Often that is from reduction in progesterone, because if you're making tons of estrogen and not very much progesterone, which is the typical picture for those of us who are 35 or older prior to menopause, we grow more uterine lining, so our periods are heavier. We often start our period a little earlier because the progesterone's disappearing faster than it used to. We can have more mood swings, more PMS symptoms, bloating, all the things, right? And much of that is due to progesterone reduction. So one of the very early interventions for perimenopause is replacing progesterone. Makes sense, right? Well, let's talk about testosterone. Testosterone's not so cyclic. In other words, it doesn't fluctuate as much during the month as the others. There's a little blip around ovulation where it's a little higher around ovulation, probably nature's way of improving our libido when we're fertile. That happens in all mammals. They call it going into heat if you're a dog, but we have something similar, not the same, but similar. But during the month, it's relatively the same every day. However, over time, it's just slowly declining. Typically, we see the highest testosterone levels in women around age 25 to 30, and then they slowly decline. Now, they can be zero as early as mid-40s. Mine was. I have other patients where their testosterone's undetectable even earlier than that. And in other patients, they're still producing a little bit even after menopause. So there's a lot of variation in the way in which our testosterone declines. In some patients, it never goes away altogether. Many patients are menopausal or years after menopause. Their estradiol zero, their progesterone zero. Obviously, they're not ovulating anymore, so their ovaries have shut down. But they may still be making a little bit of testosterone, either from the ovaries or the adrenal gland. So that one has a little more variation. But suffice to say, it just goes down over time. So putting it together, what happens? First, our progesterone starts going down. And that's the primary cause of our perimenopausal symptoms, along with this crazy up and down in estrogen. Along with that, at the same time, our testosterone's slowly declining. So absolutely not true that they're all fine and then they all stop, and that's the day of menopause. No. And I still have patients who have this idea, they've been taught this by somebody, not your fault, because we were not taught, that there's lots of hormones and then one day they just disappear. Not quite that simple. If it was that simple, there wouldn't be anything called perimenopause. And perimenopause is, without a doubt, the most tricky, most challenging time for those of us going through this journey. Now, I went through perimenopause some time ago. I didn't even know what was happening. Frankly, that was before I had any education about all of this. I was completely confused. I thought I was going crazy. I was sure I had Alzheimer's, bipolar disorder, a brain tumor, some combination of all of those. And I'm a doctor who at that time was advertising myself as a menopause specialist. So just to know, doctors don't know much about this unless they have sought out an enormous amount of menopausal education. So look for someone who is a practitioner through the Menopause Society. So we get certified through this great organization. So check that out. That's a great way to find somebody who might know a little bit more about this than your average primary care doctor, because we're just not taught about it, even gynecologists, because I was one. Now, going back to how this all happens and treatment options, if you're perimenopausal and suffering from those typical symptoms, typical is hard to nail down because there are so many and it presents differently for most patients, but very commonly, like I mentioned, heavier periods, periods starting earlier, followed by skipping periods. If you have fibroids, they're going to grow because you've got lots of estrogen. If you have endometriosis, same thing, with very high estrogen and low progesterone, that can be a problem. And then all host of mood changes, because progesterone is very much responsible for helping our mood stay stable. So those are some of the more common perimenopause symptoms, along with decreasing sex drive, because remember, our testosterone's going down as well. So all of that can be addressed. I mentioned to you checking labs. Now, people have different opinions about this. I very strongly believe that checking labs is helpful. However, it has to be done at the right time because, as I mentioned, if your hormones are going up and down, if you check them on one day versus another, you're going to get completely different numbers. So the standard, let's just go back to the standard so we can compare apples to apples. If you are having periods, now of course if you're not, this doesn't apply. If you're having periods, we want to check your hormones during your period. So typically we say somewhere between day 1 to 5, day 1 being the first day of bleeding, day 5 being the 5th day. First day of bleeding is any bleeding more than spotting. Okay, if you're only spotting, we'll take that. But just, in other words, we're trying to draw your blood on the lowest estrogen day. Why is that? Well, if you're complaining about a bunch of symptoms, for example, I have patients who say, I have hot flushes and night sweats for 3 days out of every month. And now that I think about it, it's usually around my menstrual cycle. That's because your estrogen's really low. And then the patient will say, well, and then it kind of goes away and I feel fine. And then it comes back. Well, that's because your estrogen went up again and then it went down. So if we don't check it on the lowest day, we're not checking it on the day that you have your symptoms. I've had many patients had their blood drawn. The doctor said, oh, your estrogen's fine, so the hot flashes can't be from that. Baloney, they just checked it on the wrong day. So let's check it on the lowest day. Okay, the other thing that happens on the lowest estrogen day is the hormone called FSH, or follicle stimulating hormone, will be the highest. Now, follicle stimulating hormone goes up as we get closer to menopause, because this is a pituitary hormone. Our brain is producing this hormone that is trying really hard to get your ovaries to produce a follicle, make an egg, and stay fertile. This poor little hormone is trying really, really hard. So as our ovaries stop listening as well, so to speak, we make more. So we're going to see FSH going up, and that is another sign that you're entering perimenopause or you're moving towards menopause. Now, we can't tell you based on your FSH when you're going to go through menopause, but we can certainly see progression or see if something else is happening. If your FSH is still really low during your period, maybe we need to look at other things. So if we checked FSH on a day when your estrogen is high, we're not going to see that picture as well. So we've got to check estradiol and FSH during your period. So write that down. Please ask your doctor to do that. Now, checking progesterone on that day would be pretty useless, because what is your progesterone during your period? 0. It's supposed to be. That doesn't mean your progesterone's low. That means we didn't check it on a day when progesterone should not be low. So on your period, we're only assessing estradiol and FSH. So take that to your doctor and please ask for that. Well, if you want to see if your progesterone's dropping, you don't really have to, because we just know that it is. But if you really want to see that it is, first of all, you would have to know what it was before. Maybe you know that because maybe you went through fertility treatments or something like that. So let's just say typically a fertile young patient who's 25 to 30 years old and is ovulating, if we measured her progesterone a week after ovulation, now you'd have to know when that is, by the way, but let's just say you can figure that out, it would be something like 20, 10 to 20, I mean, nice high number. Anything greater than 5 indicates ovulation. 5 is pretty puny, 10 is pretty okay, 20 is nice and strong and good for pregnancy, and you might even be pregnant if it's 20. So if you can figure out when you're ovulating, check your progesterone a week later. Typically in perimenopause, we'll see much lower numbers, maybe 4 or 5, something like that. Well, that explains why you're having those symptoms. You don't have to do that. You really don't. Because if your estradiol's low and your FSH is high during your period, we know by default that your progesterone's going to be low. But if you're interested in assessing it, first of all, you would have to know when a week after ovulation is and check it at the right time. Now, that would end up being also a week before your next period. So typically we say check progesterone on day 21 of a 28-day cycle. Well, problem with that is you're probably not having 28-day cycles, and it can be really hard to pick that day. But if you want to pick a day, check progesterone a week after ovulation or a week before your next period in any manner that you can figure out when that is. And good luck, because it's really hard to do that when you're perimenopausal. So typically we just stick with the on your cycle estradiol and FSH if we're assessing a perimenopausal patient. Now, testosterone you can pretty much check anytime. Now, to compare it to what it was before, of course, we'd have to know what it was before. And that's one of the reasons I recommend checking labs annually, because you'll see it going down, perhaps. Because we can't see change without at least 2 data points, and usually 3 is good. So that's just a little help and a little bit of information about what to do with these individual hormones. And please do not go and get your blood drawn at some random time of the month, unless your doctor's really good at putting together some detective work about where you are in your menstrual cycle. Now, of course, if you're menopausal and you're not menstruating, you can draw your blood anytime, because your hormones are the same every day. They're approximately 0. And there is an argument that we don't even need to check hormones in menopause, but I think it's important to do because not everyone's the same. After menopause, some women do produce some estradiol, not from their ovaries, but from their peripheral tissue, from body fat. I mentioned some women also produce some testosterone from their adrenal gland or even from their ovaries. But if you're getting treated, we need to know where you're starting so that we can calculate the appropriate dose for you, because it might not be the same as another person. So just a little bit of information. I hope that was helpful. If you enjoyed this episode, please don't forget to subscribe, share it with your friends, and I can't wait to see you next week.